Hello everyone, today is September 7th, the Duchenne Muscular Dystrophy Awareness Day. To honor this day, we decided to test Humber College students' knowledge of this disease, all while educating and bringing awareness to the disease.
Do you know what Duchenne muscular dystrophy is?
No.
Do you know what Duchenne muscular dystrophy is?
No.
No.
Do you know what Duchenne muscular dystrophy is?
No.
Do you know what Duchenne muscular dystrophy is?
No, I don't.
Do you know what Duchenne muscular dystrophy is?
No.
Okay, well, let me tell you about it.
We were very disappointed to find out that the students of Humber College didn't know much about DMD, so we took it upon ourselves to bring more education to them on this very special day.
So what is Duchenne muscular dystrophy?
So Duchenne muscular dystrophy is a genetic disorder which affects the muscles in typically males. It starts off around the age of 2 to 3 years old, and as a person grows up, their muscles become weak and basically degenerates over time. Life expectancy isn't very long for persons diagnosed. Typically, we see them range between the late teens to early 20s.
Duchenne muscular dystrophy falls under the category of dystrophinopathies, which are caused by mutations in genes related to dystrophin. These mutations result in progressive muscle weakness and can have a significant impact on a person's mobility and overall health. Numerous other muscular dystrophies, some of which are caused by genetic mutations in other genes, and some of which code for proteins that interact with dystrophin proteins, are caused by genetic mutations in other genes. Therefore, muscular dystrophy ends up producing many of the same symptoms as dystrophinopathies, such as the Becker muscular dystrophy, which is a less severe and it comes on later on in life. So, in Duchenne muscular dystrophy, the change happens in the muscle itself and not the nerve or neuromuscular junction. Since Duchenne muscular dystrophy is caused by mutations in the dystrophin gene, severe mutations like nonsense or frame shift mutations can lead to a Duchenne muscular dystrophy, which is a severe form of the condition. It usually appears by the age of 5. These mutations in the dystrophy gene are small changes that happen at a specific spot in the gene sequence. These mutations can involve swapping, adding, or removing a single base pair. These mutations in the dystrophy gene can cause changes in the instructions it gives for making proteins, which can heavily affect the body in different ways. Males have one X and one Y chromosome, and females have two X chromosomes. This means that muscular dystrophy is more common in boys because they only have one copy of the dystrophin gene, and if that copy is defective, it's the only available one to the muscle cells, whereas girls with the defective dystrophin gene might have another functional one. Muscle fibers of a variety of dimensions are initially produced as a result of the initial phase of muscle regeneration. But when we consider ambulation over a long period of time, the muscles' atrophy will become infiltrated with fat and fibrotic tissue, making them incredibly weak. This is most apparent in the legs. Children who have Duchenne muscular dystrophy start walking later in life and have a waddling gait. They are also more likely to get a calf pseudohypertrophy, which causes their calves to grow because of fat and fibrotic tissue rather than muscle. Another well-known indicator of Duchenne muscular dystrophy is the Gowers sign, in which a child starts flat on their stomach and tries to get up using their arms due to weakened muscles in their upper legs and hips. The mutations in the dystrophin gene can lead to respiratory failure, scoliosis, dilated cardiomyopathy, and arrhythmias. Unfortunately, these complications often result in a shorter lifespan. Diagnosis involves DNA tests, Western blot, and muscle biopsies. While there are no great treatments, glucocorticoids may help with muscle degeneration, although they can have pretty bad side effects like weight gain. Physical therapy can improve the quality of life, but it doesn't reverse the underlying process.
The pathophysiology of DMD.
Pathophysiology of Duchenne muscular dystrophy. Here we have an example of a healthy muscle cell membrane. We have our basal lamina, our dystrophin, our cytoskeleton, and our sarcolemma, as well as our protein complex. Here is one example of dystrophin and how it acts as a shock absorber. In this example, we can see how a muscle fiber membrane works without dystrophin, so it doesn't act as a shock absorber anymore since it's not there anymore, and it would leak in these intracellular neurons like kinase and other intracellular neurons. Here we can see two examples of muscle tissues. On the left side, we can see a healthy muscle tissue from somebody who does not have DMD in their genes or their DNA. And on the right side, we have somebody who does have DMD. You can see the white spots, which are the scar tissue building up. So over time, their muscle degenerates and causes the healthy muscle to turn into scar tissue. It lets all that kinase in, all those intracellular neurons, and it becomes scar tissue. Since the dystrophin can't act as a shock absorber anymore, and therefore it lets all those intracellular neurons into the muscles, into the cells, and converts them into scar tissues. The muscles in the body that can be affected by Duchenne most commonly are the legs, the heart, and the lungs. The damage of the muscles keep progressively declining as the patients get older. This makes them lose mobility, having to use a wheelchair to prevent falling and more damage to the tissues. The life expectancy for patients with DMD has reached early to mid-20s, although there is always active research with DMD. Like JF's case, aspiration pneumonia is a really common difficulty that happens to patients who have Duchenne. This is one of the leading causes for deaths within muscular dystrophy. Pneumonia usually follows viral respiratory infections of the upper respiratory tract due to the combination of increased amount of nasal and oral secretions. The accumulation of bronchial secretions leads to bacterial infection. Moreover, dysfunction of swallowing mechanism exposes these children to the risk of developing aspiration pneumonia.
The occurrence of the dystrophin protein in the person's DNA is what causes DMD. The healthy muscle will turn into scar tissue over time, causing the patient to become weaker and lose mobility as they get older.
Next, we have clinical features general to the condition. DMD usually starts during infancy or can be developed later on as the child grows. Most symptoms can begin between the ages of 2 and 4 years old. Most symptoms involve the child's lower extremity will first show signs of increasing weakness in muscles and loss of muscle mass. Less serious cases of DMD can be found throughout the neck, arms, and other areas of their bodies. Other symptoms include hypertrophy of the muscles in the calf, having difficulty going up the stairs, difficulty walking, increases as they get older, reoccurring falls, walking with a waddle, and tiredness. Other symptoms can affect the cardiac area and can cause breathing issues. Usually after the age of 30, most people with DMD had developed cardiomyopathy, which is the main cause of death in DMD. Another one is learning and cognitive despairs, impaired speech and language. They usually have delayed speech or have trouble reading. Next is scoliosis, and lastly, short height includes in one of the symptoms.
JF is a 16-year-old male with Duchenne muscular dystrophy and is currently hospitalized for pneumonia. His immobility worsened due to his hospitalization. He reached gross motor milestones on time in infancy, and he walked at 16 months. Lordotic posture started at age 2. Gower sign and Trendelenburg gait noted by ages 4 to 6. Progressive muscle weakness primarily in arms, pelvis, and legs. orthotic braces required by age 9 and a wheelchair by age 11, declining ability to use utensils, write, and type in early teens. Prior to hospitalization, he had full-time power wheelchair use.
Clinical features general to our case study. JF started to have weakness in his muscles in the first year he was born and had some learning difficulties. In the first year, he had many normal, gross motor skill milestones, such as holding his head up, rolling over, sitting, and standing at normal times. Although he did start to show more symptoms, he did not walk until 16 months old, and at 2 years old, he started to have a lordotic posture while standing but not while sitting. At the age of 4, he had a Trendelenburg gait. He suffered progressive muscle weakness, most notably in the arms, pelvis, and legs.
In terms of activity limitations, JF will have difficulty running, going up and down stairs, jumping, doing self-care such as dressing, grooming, and toileting. They will also have issues doing certain leisure activities like playing board games, cards, and reading, and these can cause falling during daily tasks due to the weakened muscles if not supported or assisted.
Participation restrictions. JF will not be able to participate in certain sports, for example, soccer, basketball, swimming, which includes being in a team. Additionally, he is restricted to using the playground with playing materials, for example, monkey bars, swings, rock climbing, and also riding a bike.
In summary, Duchenne muscular dystrophy is a genetic disorder that weakens muscles and primarily affects boys.
While there is no cure, treatment options can help manage symptoms and improve quality of life.